We will start the next session. It's a joint session between Egyptian Society of Cardiology and SACIS, and we have the honor that Professor Wael Kashkari, president of the SACIS, and he's a very active cardiologist in the cardiology and intervention community in Saudi Arabia. I witnessed that he's the most active intervention cardiologist I have seen in Saudi Arabia, and I let Dr. Nabil start.
Good afternoon, everybody. This is one of the very important sessions, and it's about tricuspid valve intervention. One of the most difficult subjects we face in our patients, especially here in Egypt. We have many patients with this valvular disease that usually is very frustrating for both the patient and the doctor as regards the medical treatment. It's my pleasure to co-chair this session with Dr. Wael, Dr. Ahmed Magid, Dr. Hussam, and we can start now with this transcatheter tricuspid valve intervention, imaging, and patient selection. And I think this is one of the very important topic, because patient selection in every subject, even in coronary intervention, CGOs, TAVI, and everything, it is one of the very important subject and basics to know for our patients. Thank you very much. Dr. Hussam.
Assalamu alaikum. It's a great pleasure to be participated in this session with our colleagues in Kingdom Saudi Arabia. We'll start with the first step in the management of cases of tricuspid valve intervention percutaneously is the assessment of the tricuspid valve and the selection of the appropriate patient with the appropriate procedure. Tricuspid valve is not just a valve, it's the apparatus composed of leaflets, annulus, subvalvular apparatus, papillary muscle, and even the right atrium and left and right ventricles are contributing with the pathology and also with the decision for the use of whichever prosthesis or whichever management for its pathology. We have to admit that tricuspid valves don't always have triple leaflets. About 50% of the population have 3 leaflets, but the other 50% may have 4 or 5 leaflets. This had an impact on the intervention and on the use of the percutaneous intervention, mainly the LTIR procedure, to know where the coaptation gaps and to manage it. We also have to have an idea about the neighboring structures around the tricuspid valve, mainly the right coronary artery. Especially when we deciding to produce or to manage the patient with the annuloplasty, and also we have to have an idea about the when we have to have an idea about the AV node position, the coronary sinus, the ostium of the right coronary artery. Regarding the topic, we have to start with the transthoracic echocardiography. What we are searching for in this study, we have to assess the severity of the tricuspid regurgitation, its etiology, whether it's primary or secondary. We have to assess the annular dilatation, the degree of tethering, the gap of the coaptation gap, and the assessment also of the right ventricular dimension and function. And very important, also it has very massive limitation, is the assessment of the pulmonary artery pressure, especially when you are deciding to do the orthotopic tricuspid valve implantation for the fear of the acute after-load mismatch, and also for the assessment of the inferior vena cava, for the assessment of dimensions between the hepatic vein and the heart and the right atrium regarding the heterotropic tricuspid valve implantation. This is the conventional echo. We start with the parasternal views. the long axis, the short axis, and then we proceed to the apical 4-chamber view, which we can use also for the assessment of the RV function using the fraction area change and TAPSI, and assessment of the 2D measurement of the annular size. We can also use the TTE 3D, which will give a very beautiful, although not common, view for the en-face view for the tricuspid valve to assess the picture of the leaflets and the coaptation gap. As I said, we have to assess for the IVC and for the hepatic flow pattern and the distance between the suprahepatic vein and the right atrium. And we also have to assess for the causal etiology, whether it's primary or secondary, rheumatic from the left to the right, rheumatic or prolapse, endocarditis, pacemaker related, carcinoid syndrome, or dilated, whether dilated right atrium or right ventricle. And here is the assessment of the severity of the tricuspid regurgitation, and we add on two more severe category above the conventional grading of mild to moderate severe. We have the massive and torrential, although their implication in the intervention and in the AIDS application is still limited. The quantification of the tricuspid valve, we use whether the jet area, the continuous Doppler spectral pattern, or we use also the vena contracta, whether the vena contracta by the transthoracic or transvagal or 3D dimensions, or can we use better X-plane method to assess the septolateral or anteroposterior vena contracta? It will give more details because of the anatomical variation of the tricuspid valve. The vena contracta area of the tricuspid is not circular. It's somehow oblong أو بنتكلم هي ممكن تبقى saddle shaped. We can use also can quantify the tricuspid regurgitation using the 3D mode by measuring the vena contracta area. Regarding the TE, which is very important, pre and intra procedural for the assessment of the tricuspid valve, we use the 4-chamber view at angle 0 with some slight clockwise rotation for the assessment of the tricuspid valve, hoping that the artifacts and the shadowing from the septum and from prosthetic valve, if any present, whether mitral or aortic, can cause some difficulty in the assessment of the tricuspid valve. The tricuspid inflow outflow view also is very important here, mainly during the introduction of the device regarding the TEER procedure. It can help us to assess whether which septum or which leaflet we have to manipulate or grasp, whether beside the septal leaflet, the anterior or posterior leaflet. And as we know all, the best side and the first side to be tackled in the TEER procedure is the anteroseptal commissure. And this is a short axis view. It will give a very nice view regarding the number of leaflets, the coaptation gap, and also will help during the procedure for the manipulation for the fixation and grasping of the leaflet by the triclip, for example. Also 3D view, it's helpful when we put a landmark like the aortic valve, and we can here put the aortic valve at the, for example, for the 5 o'clock position, and we will have the anterior leaflet to the left of the valve and posterior leaflet to the anteriorly. So we can decide the commissure to be tackled, and here when to intervene. As we know all from the guidelines European, we will find out whether it's primary or tricuspid. هل هي فيها severe RV or venous function or pulmonary hypertension. نبص على السيمتومز، لو ما فيش symptoms نبص على RV dilatation، وبعد كده we decide the intervention according to the feasibility and the operability of the patient. And in case of severe symptomatic secondary tricuspid regurg in patients considered to be inoperable, we give a class 2B level of evidence C for the percutaneous intervention for tricuspid valve. This is the European. American give no recommendation for such a procedure, just a hint about its use. Here, this slide is talking about the ideal timing for the intervention regarding the RV function. We found that in the middle, in the lower middle picture, we found that there is a significant difference regarding the outcome when we use RV function cut off from 13 to 17 millimeter TAPSE, whether below or above this level, the outcome show no difference. And this is ideal timing. TAPSE 13 to 17, also it has its limitation, as we will find in this slide. The RE function, we can assess it using transthoracic echo through TAPSE, through the tricuspid annular systolic velocity with tissue Doppler, out through fraction air change. Although these modalities have limitation regarding their sensitivity and affection by the afterload and overloading conditions as a whole. Here we can use the 3D transthoracic echo for the assessment of the volumetric assessment and function of the RV, which seem to be more compatible with the CMR results. Regarding the intra-procedural echo, there must be a cooperation and harmony between the operator and the echocardiographer. We have to assess for the size of the gap, the procedure that we have to choose. We have to choose the size of the gap between the leaflets, the annulus. We start first with the RV inflow outflow view. As I said before, this view gives a good idea about which commissure we have to target, and can use also the 3D views to give a good anatomical and on-fast surgical view for the tricuspid valve. Here the aorta, and we have a septal leaflet in front of it. Here the anterior leaflet and posterior leaflet, and almost always we have to tackle the commissure between the septum and the anterior leaflet. Also, we can measure the annulus diameter, perimetry, and circumference. In the transgastric view, this view also, as I said, is very important in the assessing of the grasping of the valve when we start to locate it. Device interrogation, we enter the device mainly tri-clip using the inflow-outflow view. We try to control its position, and we use last the transgastric view to park it at the anteroseptal commissure, and we manipulate it by clockwise and clockwise rotation so as to grasp both leaflets, and then we assess the mitral regurgitation, our residual tricuspid regurgitation after that. And in many cases, we have to add another clip, which is is located just behind the anterior of the firstly deployed clip, as this view shows. And here the final result after putting 2 clips, before, after 1 clip, and after 2 clips. A CT is very important for the assessment of the right coronary anatomy regarding the annulus, for the simulation of the device that we have to insert regarding the replacement. For the fluoroscopy, it's very important to guide for the RCA and also for the assessment, invasive assessment of the pulmonary artery pressure. Transthoracic is essential for the tear. A CT is essential for the cardioband and for the heterotropic and orthotropic valve implant. And here we have the cutoff point of the gap. The gap less than 2.5, we can use tear. More than 2.5, we have to use the annuloplasty. If there is severe tethering, we can use annuloplasty and the tear. If there is perforation or damage of the valve, we have to proceed to the orthotropic implantation. Repair is safer than replacement, but we have to be careful regarding the replacement for the fear of the acute afterload mismatch due to severe pulmonary hypertension. Thank you.
Thank you very much, Dr. Hassan, for this excellent presentation. I would like to ask you, what is the most important echo parameters, whether transthoracic, transesophageal, or a 3D echo, that we can say that this valve is suitable for repair and this valve is not suitable for repair and should be replaced.
The last slide, as I said, we have to assess for the first the etiology, the primary and secondary. Primary, if there is restriction due to carcinoid, aromatic heart disease, the best option, if we decide to do a transcutaneous or transcaster implantation, is to do the implantation whether orthotopic, which is best, or heterotopic, which means that I put two valved stent in the superior and inferior vena cava. Regarding the secondary tricuspid regurgitation, we have to assess the following parameter. First of all, the RV function. As I said in the slide of the outcome regarding the RV function and TAPSE, the very low TAPSE, the difference in mortality and outcome is there is no difference between the intervention and conservative management. The normal TAPSE, the same. The best option is to use the mid-range RV dysfunction. This is for the RV function. Regarding the anatomical details of the valve, we have to detect for the gap between the both anterior and septal commissure. We have to have a cutoff value of 7 millimeter, but they raise it for little to 8 and 8.5 millimeter. This less than this cutoff is feasible for TEER or tricuspid TEER procedure. More than 2.5, we have to resort to the annuloplasty, cardioband, to shrinken the annulus. Also, regarding the gap, if the gap is very is larger than that, sometimes our tethering, sometimes this will interfere with the possibility for cardioband. So we can give more excessive diuretic therapy and re-evaluate the annulus, because sometimes it shrinking and decrease in size and make the candidate more suitable for intervention. The coaptation gap, the coaptation distance, which is the distance between the coaptation and the annulus of the tricuspid valve, more than 8 millimeter, this is considered significant. The tenting area between the leaflets of the tricuspid and the tricuspid annulus, more than 1 centimeter also is considered significant. So beyond this, or below this, it's considered left tethering. بالتالي it's ideal for TEER. Beyond this, بتبقى في difficulty, and sometimes we can combine with the annuloplasty and TEER intervention.
Dr. Rizk, I really would like to congratulate you for this amazing lecture. I hope I have it with me when I go back to Saudi Arabia. Very comprehensive. You are a very solid echo guy. Really, I enjoy the lecture. Really, very comprehensive. I don't know, Dr. Majdi, Dr. Hussam, if you posted, all the entire meeting at your website, but this tricuspid valve pathology is an evolving is an area. So giving such nice lecture, comprehensive, people, they're gonna learn. I really enjoy it. I really enjoy it. Thank you very much.
Maybe later on we can construct like a Zoom meeting where people from Saudi Arabia and people from here, and it could be tricuspid intervention and tricuspid evaluation would be. Dr. Ramadan wants to say something, but quickly, please.
Excuse me, there is something that I could not understand concerning repair of tricuspid regurg. As we all know, the regurg in most of cases is not due to a disease of the valve itself. It is due to right ventricular failure, dilatation of the ring, that the tricuspid occurs. This occurs as a result of pulmonary hypertension. Pulmonary hypertension may be due to left-sided failure or to other causes. If you are able to correct left-sided failure or the other causes of pulmonary hypertension, the right ventricle will return to normal, the ring will return to normal, and it will correct itself by itself. If you are not able to correct this, repair will do nothing, because the cause which caused the regurg is still present, and it will recur again, and no value what you have done. Another point, that repair of the valve means that the right ventricular output will increase. Output in where? In the pulmonary circulation. This will increase pulmonary hypertension. This will add to the misery of the patient. Excuse me, this may be primitive, but I want to understand.
No, it's a very nice comment, and that's why we do right heart cath always before do any tricuspid intervention. So without further ado, we're going to introduce Dr. Fahad Al-Qahtani. He's a consultant interventional structural intervention interventionist from King Salman Heart Center at King Fahd Medical City. In Saudi Arabia, there is 2 pioneers in tricuspid valve, only 2. Out of 250 interventionists, there is only 2 who do a lot of tricuspid. Dr. Fahd Al-Qahtani is having a lot of white hair, but by far, he's a young guy, by the way. He's really younger than me, probably 10 years, 9 years, Fahad. And Dr. Sundus Samarkandi. So we decided to bring this gentleman here to participate at the Egyptian Society. And all the floor is yours, Dr. Fahad.
Thank you, Dr. Wael, and thank you for the organizing committee and for Dr. Hussain for making my job even easier. So my talk today is transcatheter edge-to-edge tricuspid valve repair using TriClip, the current evidence. So following the introduction of transcatheter technique for aortic and mitral valve disease, the possibility of lower risk tricuspid valve intervention become more attractive. However, the development of transcatheter devices of TR treatment faces several anatomical challenges. Among these challenges is the frequent presence of large tricuspid annular size, more than 4 millimeter, thin and more delicate leaflets, often with deep clefts and folds, lack of calcium for device anchoring, and also the angulation between the tricuspid annulus and the inferior and superior vena cava, making the devices in the right atrium right ventricle difficult to manipulate, and frequent presence of pacemaker defibrillator leads. So numerous devices has been in the market for years, but none of them reached to the final clinical stage except for the coaptation device. These can be grouped into like coaptation devices, annular devices, heterotopic caval valve implant, and transcatheter tricuspid valve replacement. So the tricuspid valve evolved over years, and the first use of TriClip was used in early 2016. It was a mitral clip to treat tricuspid valve regurgitation. So was a first compassionate use of mitral clip, case series of 13 symptomatic patients with severe TR. All patients experienced a good TR reduction. The New York Heart Association class improved in 84%. Only one major adverse event. A year after, 64 patients, with 88 of them had a functional TR, 34 was treated at the time of the transcatheter repair, and only 3 hospital deaths had occurred at that time. Then jumping 2018, the TRI-valve registry came out. It involved 249 patients with severe TR using the mitral clip in 14 centers in Europe and North America. And there was a successful procedural outcome as defined by lower than 2 grade TR grade in 77% of the patients. During that time, at this stage, the only device was used is the mitral clip in the tricuspid valve, and was only for compassionate use. So we moved from case series to analysis. Bessler et al. Assessed the predictor procedural outcome in 117 patients treated with a mitral clip and found that a smaller EROA, tenting area, vena contractia, coaptation gap, the presence of central and anterior septal jet, all predictors of procedural success. But only coaptation gap was the only significant predictor in multivariate analysis. And using the large clip, the XTR, in patients with coaptation gap more than 7, result in success rate down to 75% and more frequent single leaflet clip detachment that observed in more than 7 patients. So at this stage, we start to understand better the patient, and we have better echocardiographic cardiac criteria. Not only this, we also evolve in the space of the devices. Then in 2020, we first introduced the TriClip system. It's different than the mitral clip system. It has 2 knobs, flexion and extension, different than lateral and median in the mitral clip, and the presence of the lateral and septal knob. And also, if you notice, the distal curve is different than the mitral clip. This is a shorter and making the device to move easily in the right atrium and the right ventricle. All these cumulative evidence led to introduction of the Triluminate pivotal trial, was a prospective single-arm, multi-center study to evaluate the TriClip system in patients with moderate severe TR. Acute procedural success was achieved in 90%, and TR severity was moderate or less in 57 at 30 days. The trial met the primary safety endpoint. Only 3.7 patients had a major adverse event at 6 months, significantly less than pre-specified performance goal of 39. At 1 year, there's a sustained reduction in the TR grade, with almost 87.1 showed at least 1 grade improvement at 1 year. This has also led to 70% moderate or less at 1 year. This also lead to sustained symptomatic improvement and improving quality of life at 1 year. This in turn make the hospitalization even less, and indirectly procedural success predictive of mortality and heart failure hospitalization at 1 year become lower. The most striking result is the RV remodeling. Reduction in the TR causing reverse RV remodeling at 1 year. This can be explained by the right ventricular dimension, right atrial volume, and also by the TAPC. So after the triluminate pivotal trial, in 2021, TriClip became first device of its kind to receive CE mark for minimally invasive tricuspid valve repair. And then moving from this triluminate pivotal trial to real-world data, the B-RIGHT study was initiated to evaluate real-world safety and effectiveness in patients treated with the TriClip and TriClip G4 transcatheter edge-to-edge repair system. It involved 200 patients. Majority of them are elderly, 78, and majority female with hypertension and hyperlipidemia and atrial fibrillation in also more than 80%. The most intervention was mitral intervention in these patients. Most of them, 82%, has a class 3 or 4 heart failure. Ejection fraction was normal, and there is no severe pulmonary hypertension in this group. Acute procedural success was achieved in 90% of the patients, successfully meeting the primary endpoint. 90% of subjects had TR reduced by at least 1 grade at 30 days, with the majority reduced to moderate or less. And there is a majority of subjects experienced significant improvement in New York Heart Association functional class and quality of life. In 2023, the triluminate, the main trial by Dr. Paul Suraja was out. It included symptomatic severe tricuspid regurg at 65 centers in United States, Canada, Europe, and were randomly assigned to 1-to-1 ratio to receive either tricuspid edge-to-edge repair or medical therapy in the control group. All have more than severe TR with symptoms, pulmonary arterial pressure less than 70, so they excluded all patients with severe pulmonary hypertension. All of them received stable, more than 30 days guideline-directed medical therapy for heart failure, and they don't have other cardiovascular condition that need intervention or surgical correction. So all these patients goes into heart team discussion, intermediate or greater surgical risk as determined by the local heart team, which consists of board-certified specialists in cardiac surgery, interventional cardiology, and echocardiographer. It included 170 patients in each group. Majority of them are elderly, as we see with the B-RIGHT study. Also, majority of patients treated for tricuspid female. And you can notice that almost 90% have the atrial fibrillation or atrial flutters, telling that the primary reason is the functional MR. And there is almost 16% presence of devices in the tricuspid, including CRT, CRTD, ICD, or pacemaker. And we coming to the primary endpoint was not a composite endpoint. Was one win-to-win ratio. It includes hierarchical composite of death from any cause of tricuspid valve surgery, hospitalization for heart failure, and improvement of more than 15 points in Kansas score at 1 year. And the difference was 1.48, reaching as clinical significance. And the main thing was a change in the quality of life in the TEER group compared to control group, with a difference of 11.7. So they concluded that tricuspid TEER was safe for patients with severe tricuspid regurgitation, reduced the severity of tricuspid regurgitation, and was associated with improvement in quality of life. earlier this month, probably the first week of February, we heard about the FDA panel fought in favor of TriClip system to treat severe TR. So we are reaching the final stage of FDA approval for the TriClip system. And toward this precision, we're still early in the learning curve of TriClip space. And we did not achieve the success rate we observed in the MitraClip experience. Procedural success is often limited by anatomical and technical challenges, and the co-optation gap identified as one of the essential parameters influencing the procedure success. In order to have a successful procedure, you have to work on the co-optation gap, either by the echo or pre-procedural. Since co-optation gap is a predictor of procedural success, multiple technique has been proposed to reduce the co-optation gap and improve procedural outcome. Among them is the introduction of the G4 system that integrated independent grasper, so you can take each leaflet independently using the integrated G4 system. Also the presence of larger, wider clips, so now we have 4 different kind of clips to use. And optimal diuresis prior to the procedure. I think this is the most important things before taking the patient to TriClip procedure is to diurese him very well and do right heart cath and make sure that patient is very dry before doing this. The other thing is during also the procedure is lowering the tidal volume during the procedure, and this is help during the passive cardiac motion when you're placing the clip, especially with the second clip. You ask the anesthesia to stop breathing and then grasp. The other technique also to reduce the co-optation gap is bicuspidization technique or zipping technique. You're starting more commissural, then you're moving toward the center and then closing the gap. In summary, TEER using TriClip device is a promising technique that has demonstrated procedural feasibility, safety, and satisfactory midterm outcome. However, some issues as patient selection, optimization of intra-procedural result, and long-term data should be addressed in the future study. And by this, thank you.
Thank you very much for this very interesting and very specific situations. I think not everyone in the intervention field is doing such intervention. I'm sure it needed a lot of long time experience to build up. So what's your advice for those who are interested to have such experience in such conditions?
What's your advice for the people who want to start tricuspid?
Which cases to start with?
So usually when you start tricuspid program, you have to have at least like very well established mitral program. So the TriClip program usually mimics the experience that we have in the mitral clip space. So you have to have like a very good team, very good structural echocardiographer, you have a good cardiac surgeon, and you have like very good team to start the mitral clip. And I think by the criteria, if you have like good enough number and experience with the mitral clip, then you can proceed and start the TriClip program. Usually started with having like a proctor, collecting like 4 or 5 low risk cases for tricuspid, then starting the experience with the proctor, and slowly with the learning curve you can reach to the like working independently with the TriClip.
From your experience in both mitral and tricuspid clipping, the number of clips you need to treat the regurgitation in both valves, which valve needs more clips usually for treatment of the regurgitation, or this doesn't make a difference?
Usually it's a learning curve. We see with the mitral clip, with the mitral clip area, we started with like, usually we end up with like mean of 2 to 3 clips per procedure. And now with the development of the design and with development of evolution in the system, we saw majority of the time that we treated mitral clip with only one device. With the introduction of the like larger and wider clip, usually we can target only one clip to treat. So we started this again with the TriClip. Now with the TriClip, usually we ended up with like a mean of 3, as you see in the early experience when we have the old system, the mean of 3 per procedure, and now we are down to like 1 or 2. So mean 1.5 to 2 as we see in the Triluminate trial.
Thank you very much for this great presentation. First, just to answer the questions, my friend, that any disease on the left side, like severe aortic stenosis, severe mitral regurgitation, should be corrected first before trying to repair the tricuspid valve in secondary tricuspid valve regurgitation. And this is to answer his question, this is number one. And one of the criteria you mentioned that the pulmonary artery pressure should be less than 70.
Right.
Because we have a lot of patients of rheumatic heart disease and we do a balloon mitral valvuloplasty, we notice that this pulmonary hypertension, part of it is reversible and part is not reversible. Do you test for reversibility of the pulmonary hypertension in such patients? This is number one. Number two, you mentioned here that you select patients intermediate and high risk. And contrary for example, patient with secondary mitral regurgitation, usually we select patients who are declined by surgeons. And in this situation, the heart team is very important, and so we have to have it in our center if we are going to have a program for a mitral clip and tricuspid valve repair. Just to summarize, number one, do you test for reversibility of the pulmonary hypertension in such cases? And number two, what about the decision of the heart team in a patient with tricuspid valve disease secondary?
So I agree with you that for any tricuspid valve, you have to treat the primary pathology before you're proceeding with just correcting the leaflets. So as we start to understand the TriClip is not like, as we thought, is like it's a forgotten valve, but we start to understand more the pathology. Majority of the cases in the functional MR that is isolated tricuspid related to the RA or RV is mostly related to the atrial fibrillation or atrial flutter, causing remodeling of the right atrium, dilatation of the annulus, and making worse. This is the most of the patient that will benefit from the TriClip, not the patient that have a left-sided disease and then you bring him to treat the tricuspid and leave the primary problem. So majority of the cases that selected here is primary pathology is the functional tricuspid, not related to the left side, and we try to avoid the pathology of the left-sided. So I think with the early experience, we're still in that stage of like good selection of patient that has pathology in the right side of the heart, right atrium, right ventricle, and related to atrial fibrillation. There is also an area of interest in like trying to treat atrial fibrillation and see if there is a reversible pathology that we can correct even before we're proceeding with the TriClip. So the second question, what was?
It's about the heart team discussion.
Yes, the heart team discussion. What I mean by low risk and high risk is like for the leaflets and the clip procedures. So you low risk is like you're choosing like the gap less than 6, and you're choosing like very good imaging. There is no ICD devices. This is what I mean by low risk procedure. And majority of them should be excluded by cardiac surgeon, and it's not for cardiac surgeon, by cardiac surgery. For isolated tricuspid valve, as you see in the surgical literature, if it's isolated without left-sided disease, the mortality reach up to 27% at 1 year. So it's not the primary procedure of correction for the tricuspid.
So let me suggest that you are going to present the next two presentations. So you will give other presentations, or that's
Another two.
خلاص في presentation تانية مش كده؟
اثنين وثلاثة.
خلاص, you go ahead, you give the presentations, and then we'll leave the discussion to the end. Okay?
Do you have the presentation? Second and third. Not this one. So Dr. Hussam make it even easier to talk about TriClip case-based approach. So we go over cases. So the first case is 75 years old female. She has history of atrial fibrillation and chronic anticoagulation, heart failure with preserved EF, type 2 diabetes, hypertension, rheumatoid arthritis. Presented with the New York Heart Association Class 3, peripheral edema, fatigue. She had 3 admission over the last year for right-sided heart failure, requiring a sitting tab and prolonged hospitalization. Very sick patient, coming again and again to our hospital with a severe TR. Echo, normal left ventricular ejection fraction, reduced RV. She has a torrential TR, severe dilatation of RA and RV. There is no left-sided disease here. This is purely right-sided, and mostly because of the long-standing atrial fibrillation. So we did right heart catheterization. This is after diuresis. Mean right atrial pressure is 12, still high. RV is 31/6 with the end diastolic of 9. Which pressure is 15? PA is 26/16 with the mean pulmonary arterial pressure of 22, so no severe pulmonary hypertension. And good cardiac output and cardiac index, and pulmonary venous pulmonary vascular resistance is less than 3. The tri-score system is usually the same as we use with the SDS score in CABG. Mortality is 14%, patient is at high risk. So we have a heart team discussion, and patient was not a candidate for surgery. Usually we do also a coronary angiogram to make sure there is no involvement of the left system. And here there are 2 pictures. One showing how torrential the TR is extending from the base to the center, and you can see the 4-chamber torrential TR. Usually we proceed with the TE to assess the visibility for triclip, and you can see here the jet is wide base. You can extend from anterior septal to central to posterior septal. This is another view also showing torrential TR. We usually do also echo, and you can see in the 3D echo, you can see the gap is central, and most of the jet is anterior septal. With the glass view also you can see it here. You can see the gap and the jet coming from that gap. And transgastric view showing how wide is the gap. Coaptation gap was 5 millimeter, is acceptable. Tricuspid 3D, vena contracta area 1 centimeter, and the mean gradient was 1. We proceeded with the first clip, and you can see we placed the clip. This is X-plane in the inflow outflow, and you can see the X-plane of the clip in between the septal and the anterior. And there is a good grasping, and we control the jet into the anterior septal. I mean, there is a left thumb in the central gap. And you can see here in transgastric, we have the clip. You can see the clip here is in the commissural view, and there is a still residual gap. The gradient is 2 after placing the first clip, and then we proceeded with the placing another clip just toward the center, and you can see we controlled the gap. So we placed 2 clip, one anterior septal toward the commissure, and the other one is central. And you can see we achieve a very good result with a reduction of TR from like torrential down to mild. And this is after placing the 2 clips successfully. And this is a clip, before clip, and 4 weeks following transthoracic echo, and you see great reduction of the TR. And you can also see the function of the RVs starts to improve. And this is another view showing good result. So this is the second case. 75 years old female, heart failure with preserved ejection fraction, atrial fibrillation, hypertension, CKD, bronchiectasis, hypothyroidism, gouty arthritis. And you can see most of my patient female. I would say we did like almost 70 or 80% in females. New York Heart Association 3, poor appetite, volume overload. And usually their symptoms, female or elderly, they don't come with the typical symptom. Usually they come with the like first symptoms is poor appetite, weight loss, and then volume overloaded. Patient had 3 admission for right-sided heart failure over the last 6 months. Tri-score is 6 out of 12, mortality of 22%. We have the heart team discussion. Patient is elderly, frail, and will not benefit from surgery. And this is what's like purely right-sided pathology. And you can see this is a TE showing wide base jet, very severe and torrential TR. And you can see this is in the center. And you can see the jet extending like posterior septal, central, anterior septal, everywhere. And this is probably higher risk than the first patient we saw. We introduced the first clip, and our plan is to go, as you can see in the explain, to go anterior septal. So, want to mention things about the device. If I go back, you can see this, the device is like just placed toward the septum. With the new tri-clip, we don't use it with the mitral clip system, but with the tri-clip system, you can move this lateral by, there is a knob inside the system, and you can move it. And you can see here, after the second view, we move it more laterally. So this is one of the functions that we have in the tri-clip system than the mitral clip system. So then we have the good orientation and good placement. And you can see the two leaflets sitting on the clip and ready for grasping. And this is after grasping, like 60% grasping. And after grasping, you see good reduction, and we get rid of the anterior septal jet. So the question now is, we still have like central and anterior posterior, and posterior septal jet. So now some of colleagues will say, this is a good reduction, and you have to stop here. You have like, you already achieved +2 reduction. You can stop. But if you want to go eliminate more of that central and posterior septal jet, you have to go after it. And I will show you another case why we are going like aggressive now with the tri-clip. So this is the second clip placed between the septal and posterior. The first one we put it septal anterior, then this one we put it septal posterior. It's slide. And you can see, we place this with good reduction and down to mild. As you can see, we started with like very bad torrential TR, and we did the clover technique to control the jet. So one is putting the posterior septal and anterior septal in a technique called clover technique to control. So this is the after placement of the two clips. And you can see, even with the torrential, very bad TR extending like everywhere, tri-clip has a role here. In summary, tricuspid TEER is safe for patients with severe symptomatic TR, reduce the severity of regurgitation, and associated with improvement in quality of life. Imaging play a crucial role for understanding underlying mechanism of the disease, selection of the appropriate patient, as well as intra-procedural guiding. Right time for the right patient and appropriate treatment device. Our team approach, patient selection, and good imaging are the key for successful tri-clip program. Thank you.
Thank you, Turfad. Any question?
تفضل.
تفضل. احنا الوقت خلص بتاع السيشن عشان في ستاند الون تحت.
Second question, please. ما سمعته.
Anticoagulation post-clipping,
Clip,
I'm
yeah.
asking about it. And is there a risk comparable to the valve transplant?
First question, you can see from TriLuminate, from our experience, from majority of the patients with a tricuspid pathology is due to atrial fibrillation. Majority of them, they are in anticoagulation. I would say 95% they have atrial fibrillation and they are in anticoagulation before we even started. But the same thing, you would say patient has no atrial fibrillation. Usually you just go with the aspirin as we do with the mitral clip. So there is no other consideration. At the second clip, yes, you can proceed with the transplant if the patient is going for transplant. Is that your question? Yeah.
Thank you very much.
Thank you very much. Thank you for the Saudi Association. Now we have to. في عندك محاضرة دي؟ Okay. في stand alone دلوقتي. لا ما خلاص.
This is very quick case, difficult case.
Okay.
So this is different than what we saw with the first two cases was like purely right-sided pathology. Now we have like a combined pathology, more complex. This is two in a single procedure, combined approach of M-tier and T-tier, the mitral and tricuspid. So we have this 79 years old, very old patient with atrial fibrillation and chronic anticoagulation. He has ischemic heart disease, BCI to AD and RCA in 2020, heart failure with ejection fraction of 25%, type 2 diabetes, hypertension, and stage 3 chronic kidney disease. Patient came in with New York Association 3, peripheral edema, fatigue, mostly right-sided. Patient has like left-sided pathology, but most of his presentation is right-sided. He has 5 admission over the last year for right-sided heart failure, requiring ascitic tap, prolonged hospitalization more than 1 month. Ejection fraction is 25, moderately dilated LV, grade 3 diastolic dysfunction, moderately reduced RV, and this is usually a high risk. Usually, for the early experience, we try to avoid reduced RV. This patient with moderately reduced RV, and we know we'll see as we go now. Severe functional MR, torrential TR. We did right heart catheterization, and after aggressive diuresis, mean arterial pressure still high, 12. Wedge pressure 16 with a V wave of 21. This is aggressive diuresis. Patient was there for a month. Thick cardiac output and cardiac index is low. He is in maximum tolerated guideline medical therapy for at least 1 year. So he failed everything. He's elderly. Is there an option for this guy? Our team discussion, patient is not candidate for surgery. He doesn't have like impressive mitral disease. He has like moderate to severe. And you can see here is like central, is all functional. But the main drive for his symptoms is the right side of the heart failure. And you can see the tricuspid with the torrential TR. We proceeded for evaluation for the mitral clip. Patient has very generous area. If it is more than 3.5, usually acceptable on the baseline gradient of 2. He has very good leaflet grasping. We proceeded with a transeptal puncture. We move the device into the right atrium, placed centrally, very nicely between the anterior and posterior, ready to go inside. We split the jet into 2, going inside, and you can see the clip and the leaflet sitting nicely on the clip, ready to be grasped. We just push the grasper and have a good result with this. Ended up with only very mild mitral regurgitation. One would say, I would just do this and come in 3 months and treat his TR, but I know this patient. I follow him for a year. I know most of his symptoms is right-sided. Before I proceeded with fixing the right, I have to do something about the mitral. If I fix the right, probably the mitral will become worse and become difficult to treat. So I decided to go with the mitral clip first. Then I proceeded the same procedure with the fixing the tricuspid. So I placed the first clip in the mitral area. Then I moved to assess his tricuspid valve. Went with the first clip, nicely placed between the septal and anterior. And you can see he is very commissural. I'm almost touching the commissural. And you can see it here. I have a good reduction. It's only mild. From torrential to mild is very good result. And patient was like very well diuresed before the procedure. And you can see, I don't see any gap here. Very satisfactory result. Ended up like this. Good result. I placed the second clip. Done with the procedure. Patient discharged home after 2 days. Follow up after 4 weeks. Mild residual MR and at least moderate TR. TR came back again. He was in very appropriate medical therapy. Follow with me for like every 2-3 weeks. At 6 months, LASIK requirement increased. He required heart failure clinic visit for IV LASIK once a week. In our clinic, we don't send the patient for the ER. We bring him to the clinic, we do labs, and we give IV LASIK discharge. Just to I make sure that my patient will not come back to the hospital. Reduce rate of hospitalization. This patient, I try my best. Give him LASIK, IV LASIK. I call his son, and try to just to avoid, to control his symptoms. But I know his RV from the beginning is bad. So I decided, okay, I will admit again. I admit again, I did T. I don't know how this just came back. I don't know how this clip came back. And now he has a central. And I decided to go with another procedure with another clip. So I put clip in the posterior septum. And I achieved good result with the mean gradient of 2. So evidence for combined M-tier and T-tier is very limited. Case series and registry. The one we have is a combined M-tier and T-tier Sub-study of tri-valve registry showing lower one-year mortality compared to matched patient from the TRAMI registry. Recently published registry data suggest combined TEER is safe, effective, and improved clinical outcome compared to isolated M-TEER for combined pathology. So what is the advantage of doing both at the same time? Combined TEER approach, close mirror what is recommended in the guideline for surgical intervention for TR in the setting of severe MR. It avoids a second invasive procedure, especially in very elderly and potential frail patient. It appears to reduce heart failure, hospitalization, and mortality. So in summary, a residual significant TR after M-TEER is independent predictor of increased mortality. And combined TEER is safe, effective, and showing promising good result. However, RCTs are needed to prove this concept. Thank you.
شكرا دكتور فهد. For the,
You made it like a nice sandwich for us.
for the sake of time, we'll end this session.